I think I might try pop into ChatGP tonight. Typical St Charles Gardner Hospital patient coming for elective knee arthroplasty. I think it'll be different to that patient over there. We're going to now have some questions now. Yeah, just going to invite. Yeah, perfect. One more. Of course. Yeah, so I'll just invite the speakers back up. Have a seat over here, guys. We don't have any roaming microphones, so just raise your voice. If someone can't hear, I'll try and repeat the question if I can hear it myself. But yeah, do we have any questions at all for any of the speakers? Yes, Sam.
Yeah. So it was Miles, wasn't it?
Yeah.
Can you tell, I'm Sam,
Yeah.
Can you tell me your patient characteristics for knee replacements? That's question one. Question two, are you doing any blocks for your knee replacements now? And question three, can you give me some sort of indication of surgical time?
Yep. Okay. So first of all, we don't have any specific. It's just patient by patient exclusion criteria for Busselton. It is a lower acuity hospital, but we are taking BMIs of 40 to 45s. We're dealing with most comorbidities. Anyone that we feel has a risk of obviously needing high dependency post-operatively is immediately gone because that's up the road. But we are still doing, we're doing up to 80, 85-year-olds and everything. So there's not really any, I suspect it would be probably pretty similar to just any of the private hospitals in town. All of our knees get an adductor down catheter, except for one surgeon who was the first surgeon who doesn't like regionals, but everyone else gets an adductor canal catheter. They all get a, because we're discharging them so early, they're all getting a bolus of 15 mils of 0.2% Ropiv with dexamethasone on removal of the catheter on the day they're getting discharged. So they just go around, hang around there with it, topped up, pulled out, and we haven't, one of the surgeons was very concerned of rebound pain with that, which I think his experience is purely based on shoulders, not on knees, and we specifically targeted that in a lot of our questions and found no difference. What was the last question?
Surgical time.
Surgical time. So unless I'm relieving someone else, I only work with the same surgeon, and his tourniquet times are between 50 and 70 minutes, depending on whether he's got a registrar, and he takes the tourniquet down 11 minutes after the cement, and he probably takes another 5 minutes to close. So it's an hour and a half, sort of hour 20. He's really fast at hips, but when the registrars do a hip or it's a difficult hip, we're going out to sort of 60 to 80 minutes. So, but in general, most of our cases, all the surgeons, is in and out of theatre within 2 hours.
Yeah, thank you.
Yeah. Hi, Miles. Nick Crawford. Just going on from post-operative analgesia, I mean, you obviously talked about preloading quite a big dose of tibenidol so at the beginning, pre-op. What are you using post-operatively? And what other adjuncts are you using?
Yeah, so basically, essentially the recipe that I have is that every patient's getting 1 gram of paracetamol, 100 to 150 grams of milligrams of tibenidol pre-operatively with the tranexamic acid, and then in recovery there, and then from there it's Celebrex. They'll have paracoxib intraoperativity. They'll have Celebrex by 6 o'clock that night. Obviously regular paracetamol, and then I tend to have mine on. Generally, they're going to have 450 milligrams of tapentadol in the first 24 hours, and then I'll box off the evening dose for APS to decide the next day whether they drop it straight down to 100 or they keep it at 150. I was using I was actually, not that the pharmacist was happy about this, or anyone who knows pharmacology better than I do, which is probably most anaesthetists. I was doing TDS dosing for a while because it was just easier to just go, I just did 150, 150, 150, and then I could just stop the middle dose and then move to 150 BD. Most of our patients are having slow-release tapentadol for knees out to 3 weeks. So we generally discharge them with 3 weeks worth of scripts, but we confidently do that because we're calling them so often throughout, and we don't have any problems with that sort of thing. Did that answer it? Oh, I couldn't hear a whole question, so I wasn't sure.
Thank you.
Mitch.
Thank you very much, Miles. I'm interested by the clonidine in the spinals. A little bit of clonidine use in obstetrics in Perth sort of proved a lot of hypotension and sort of fell out of fashion.
Yeah.
How have you gone with your hips and knees with a bit of clonidine?
Yeah, well, maybe it's a combination of going to prilocaine with the clonidine. We've had a reduction in our hypotension, which is probably the prilocaine more so than the clonidine. But I think also because we've now got the system sort of down pat and the nurses are expecting how it's going to go, because there's a lot of teething problems with just simply the fact they came out with no catheter and they had to take them to the toilet, and they felt that the physio needed to see them first, and it was just, there's a lot of education we need to do around that side of things. So what we noticed as soon as the early mobilisation appeared to be a greater contributor to reducing the hypotension than whatever spinal or clonidine we were doing. So we were, and this is all anecdotal and it's clearly opinion, and I'm not a surgeon, so my opinion is not fact.
How often are you using clonidine at the moment?
At the start of the registrar's term, I use it less, and as the registrars are allowed to do more, I put more in. So basically, if you come in from about March to June, you get more clonidine.
So, Mark, sorry, with that clonidine, are you sort of getting over that hypertension with some oral midodrine use? So you guys using a bit of that?
Yeah, so we have been using midodrine if we need to, and we're trying to get that early. But it's hit and miss because we've just got a lot of variability between who's the duty anaesthetist on the day, and our system's quite different to what you guys would call a duty anaesthetist, because our duty anaesthetist will often have to deal with the patient's physiology and a lot of stuff that the medics would deal with, because we don't really have medics. So, and then you've got some of them that refuse to do that. So, because they're an anaesthetist and it's got nothing to do with them, apparently. So there's a lot of inconsistency, and that's the real problem around that. But with my patients, if I'm asked about hypertension, I will start them on midodrine as soon as I can, and Luke's probably the same, but it just depends on who you've got on what day, basically, unfortunately, because it's just an inconsistent system that we've got, unfortunately.
Brian.
My question is for Nick about how you store and have access to the videos that you're having. I mean, we've had nightmares for 20 years trying to deal with the echoes. And it costs an absolute fortune. When I was head of department, I had to spend nearly $300,000 on storage facilities for the echoes and how we have access to it. So what are you doing with that?
So I pretty much just walk around with a USB dangling on the But I don't have that many, and I've got like a probably have 50 or 100, I'd say, so it's not huge numbers, and it's just me doing it. So I think we've kind of had discussions around the departments if you were to be longer and bigger as to who would take governance over it. So it would be probably
It's not really at that point yet.
Yeah.
Okay.
I have a question for Nick as well. Do you know of any places either within Australia or internationally where they're making it mandatory to record all blocks?
I don't know. No, I haven't done search, to be honest. Yeah, no. Interesting.
Two more questions. Can't see who they are, but feel free just to shout out.
I have a question to Michael Collins. Do you have a record of where exactly were done, at which level the adductor canal blocks? I was just wondering whether the anaesthetists were targeting the vastus medialis or not at the single shot compared to the catheter, and whether that could be an implication in the appearance of the anterior pain in the knee. Because maybe with the catheter we can think that the diffusion of the local anesthetic cephalic could be covering that component, and maybe that is compensating just a potentially bad technique or just different technique. I know that some people tend to spare not blocking the nerve by avoiding a muscular blockade. So
yeah,
weakness.
it's an interesting point. We didn't look at that data specifically just because we wanted to simplify the data collection essentially as much as possible. Because it was all done by other people, essentially all with goodwill. So we just wanted to make the data as simple as possible. But it would be an interesting division to look at to see whether there was any difference between those techniques.
Thanks very much for the talks. Can I ask Dr. Earle and Dr. Ward about their thoughts about the consent process for SAS drug use, and then for a record of the patient's image which doesn't sit within the medical record?
Essentially our conversation was explain to the patient that we had got access to a short-acting drug that was new to Australia but had been around for a while, and that was my standard line for all patients for the same thing, which I didn't document, which maybe I should have, but yeah, I didn't, I don't, and I can't actually speak for my colleague whether he did or not. Everyone sort of at Buston has sort of adapted their own little shorthand things with documenting their consent, because I can't remember whether you guys in the Metro had the same consent form as us, but have you guys got the two-sided one with the whole pile of stuff and then they sign on the other side? Yeah, same up here as well. But a lot of us will have like some people just use stickers and it'll say consent obtained or consent reconfirmed on the day, and that's probably as far as we've been going. So it's yeah, probably not ideal, but it was a pretty cumbersome process and pretty tiring by the time we got there.
And for my process, we kind of discussed it as a regional department, whether there need to be a formal consent process or not. We decided because it was mostly de-identified, and when the video files are exported, that they're completely de-identified, that the URM doesn't go across, that it didn't need to be a formal consent process. We still obviously consent for the regional and get to a verbal consent they're happy for the recordings to take place. The recordings all stay on the Sonosite machine, so they're not leaving there. The ones that do leave are de-identified. So I think if we were to go to a more sort of robust recording every block policy, then it would need to be sort of uploaded onto one of the image services, and that would be the sort of more formal then consent process. So at the moment it's just sort of consenting for education, their videos to be used as educational material.
Just a question for in terms of your choice when you were transitioning from the bupivacaine to the pilocaine, did lidocaine ever be a consideration as a? I mean, like when you chose one choice, in terms of it's just interesting to see.
It didn't from my side of things, but at a guess, it probably did for Luke. He spent a lot of time looking into this and trying to work out how to do it. But I was sort of quite happy with how I was going with the low dose bupivacaine, and then sort of prilocaine almost landed on my lap because Luke went off and he really wanted plain prilocaine, but we couldn't get it. So we used the heavy, and mainly because we just wanted that little bit longer time that we should get with plain. But yeah, it was not. To be honest, I briefly thought about it, but it was not on my radar to do more research into it, unfortunately. But yeah, it's worked out pretty well anyway with prilocaine, so it's consistent enough.
Oh, thanks, Mark. Along those same lines, obviously SAS forms are very, very difficult. Prilocaine is available for Beers pockets in a 0.5% solution. Having used that as spinal, you get the same result, it just takes a little bit longer, and you have to use a big syringe, which is a different mindset. Did you have that available, or did anyone? Did you think of?
Well, no, yeah. So I mean, because we've been waiting for our non-SAS stock to arrive, I kept on checking in pharmacy to see whether it was there, and there's always been the massive vials of 0.5% sitting there for Beers blocks, which no one in the anaesthetic department does. So I don't even know why they've got them. I presume maybe ED come all the way upstairs to go and grab one of our vials or something. But yeah, we hadn't looked too heavily into that, and you know, it's obviously an option, but I think I don't know, it just feels weird using bigger than 3 ml syringe. I don't know.
Ed.
A question for Miles, just about you said you discharge patients with 3 weeks of Dependol.
Yep.
I just wondering, do you have like any, can you sort of gauge how much opioids are people on percentage-wise for a month post-op or 2 months? Or,
so what do you think about percentage of?
You're collecting data on the post-op opioid consumption?
Oh, so how many are still on it?
How many after a month are still on opioids or at 2 months?
I wouldn't know off the top of my head, but there's a very small number receiving the 2-month phone call, so most people aren't on it at then. And when we discharge them, because we don't have a hospital dispensary, the dispensary's up in Bunbury, so everyone gets prescriptions, and our APS nurses will go through with the patients and work out what's best for them, whether we will just email the scripts to their pharmacy or we'll organise website packs for them. But generally, it'll be there's 150 when they're leaving, they'll just be on 150 BD for a week, then 100 BD for a week, and then 50 BD for a week. Or if they're going home on 100, it's generally about 10 days and 10 days with 100 and down to 50s. So, but it's a pretty small, and you know, we can only go on what, when I say that they get a 2-month phone call if they're on opiates at 1 month, that's if they're still taking PRN tramadol, that we'll still call them. So it's not just the slow release stuff. So, and it's mainly because it's, well, I mean, for those people in the administrative side of things and want to know that the APS nurse making a phone call to the patient attracts a small amount of NW hours, which actually equates to about $100 to $150 per phone call that the nurse makes. So our APS nurses pay for themselves in these phone calls.
It's just an excellent example of opioid stewardship. I think everyone can follow that. I think it's just, you know, that was just amazing.
Yeah, I mean, it's really hard to convince the administration to pay for these things initially, because because we've sort of designed the position as a perioperative position, but we had a 6-month project where one of our pain nurses was doing all the pre-operative stuff and was basically just assessing which patients were going to be suitable for us and who needed to be seen sooner rather than later. Because one thing I probably didn't get across is how our system is very different to a normal public hospital, because it's essentially a semi-private. So all the surgeons are private and see all the patients in their own rooms, but the anaesthetists are VMPs, but they will see their joints in the hospital, and then they see all the other services within the hospital. And the biggest problem we've had all along has been integrating different computer systems from the surgeons' rooms to who all decide to use a different format for how they actually submit their lists to the hospital and when they submit their lists to the hospital. And so trying to integrate those two things together has been one of the biggest barriers for the whole thing, just to simply know which patients we're going to actually see and be able to assess them in time to be able to cancel them or postpone them if there's a reason not to, and then find another patient to go on that list. And it's that's been probably one of the biggest challenges, and we got our APS nurse to do all that stuff, showed benefit to the whole thing, but the project finished and then there was the state government freeze on FTE, so the position has disappeared. And even since that, in the 3 months, we've probably had 2 or 3 patients cancelled 2 days before surgery because they would have got picked up by that person. So having that sort of system where you're following them from the very start to the very end, I think is just, it's the ideal world. It's just trying to convince the administrative people to pay for it, basically.
Thanks, guys. I think that was great. So just a couple of things, Nick. You were saying, where do you go? And at the moment, you're using the blogging as educational. I've got 2 colleagues. I'm not that sexy as an anaesthetist, but I have 2 colleagues that are basically pushing the surgery boat out as far as videoing their blocks, and then you get a little copy, just like they get a little copy of their scope or their knee, they get a copy saying, this is the sexy block I did for you, along with your substantial gap. But it's quite it's quite it's the next level of care, and along with the sort of platform that you get the little text the next morning that says, hope you're travelling very well with your regional and your analgesia, or I'll check on you. So I think it's early days, but I think potentially that's where we're heading from that point of view. I'm obviously a pro the catheters, so but that's I think where we're going. Michael, as far as your talk goes, I mean, I think that was great, and I think what it does do is every time you do these things, it asks more questions, and we want to find more and we want to be better. I think as soon as we get complacent, that's when issues come. One of the things that would be valuable is certainly with the pain service, and I think that's probably across the board with all the pain services in Perth, is we respond when we know what the journey looks like. So it would be nice to know kind of what interventions were done. I know how I respond when I see a big lump of lard in front of me with really bad anxiety and it doesn't look like she's going to fly. I intervene knowing that block's going to wear off and she's got a primary ACB. That's gonna go, and there's interventions we do, maybe non-opioid. So you then get a picture that their pain scores are not a hell of a lot of difference, and the way they travel functionally is not a hell of a lot of difference. And if you looked at PRN analgesia at morphine equivalents, there's not a big difference. But we've done some other non-opioid interventions along the way, and I think that sort of sometimes we're not finding what we're looking for because we're getting better at multimodal stuff in the background. The other thing is that if you looked at the patients that we excluded, and I was speaking to Sinead about this earlier, 100% of those got catheters. So we all know catheters work. We know if it's the patient's, oof, this patient's bad, they get a catheter. But if the patient's, they don't get a catheter. So I think often we answer the questions ourselves, and then we have discussions about whether we should put catheters in.
Yeah, I think that's fair enough. Do you have a suggestion of how we go on from then?
I think you're right in the conflicting studies, because a lot of them are looking at either rest or looking at the first 24, maybe pushing 48 hours. I mean, some of the studies don't even have catheters in, and they just give a bolus the following morning, and then that's their catheter versus, single shot. Well, the single shot's still working. So some of those are just, how do you compare those two? But I think what would be interesting is, and the question for Miles, what they do is, we've got more and more patients in the cohort that are having knees that have got mental health issues, and they're all on medication, and they will gobble lollies, man. You give them lollies, they're going to gobble them. So we intervene. They're on non-opioids. We use gabapentin or pregabalin. We use some clonidine, PRN. Some of them get ketamine. We're intervening along the way to compensate for a lot of those. So it'd be interesting to know, when I say pain interventions, what is either the anaesthetists themselves, like Miles, you guys are all doing it yourself. You don't, you are the service, and some of the other hospitals, they're doing everything themselves as well. So you're getting the call, you're adding, and maybe we're not, the guys who do single shots are doing other pain interventions and doing a bloody good job, because their pain scores are, pretty much the same, and they're not using, to avoid that problem with opioids down the line, because we want to choose wisely. So yeah, maybe looking at pain interventions, what else we actually add is a good idea. Miles, are you guys using any other adjuvants? Or you've just got people from the country, and you've got surgeons that say it's going to be sore, you're going to be fine?
Yeah, I mean, it's certainly we one of the things that we do, I think we do really well, is our preoperative joint seminars. That someone decided that it was a really good idea to replace it with an app, and that was a resounding failure, and the whole people couldn't use it. I tried to use it, and it takes forever just to get through all of the wax just acknowledgements to actually find anything useful. And by the time we'd done that, I did a video on that thing, and by the time it was all trying to be used in commonplace, I'd already changed what my practice was, so my mindset was completely different. So, and we are sort of adapting all the time, but so myself and Luke are the two people that do the joint seminars, and we give a consistent message all the time of pain expectation, early mobilisation, and just reinforcing the same things from the start. And that's also reflected in our preoperative clinics with the same patients that we are, we spend most of our time just talking about that. The demographics of the country are probably a little bit different, but I mean, if I'm anaesthetising a farmer, I literally just write my anaesthetic chart farmer, because I feel that tells everyone enough that they're not going to spend any time in hospital, they don't need any pain relief, and just being right. But we still have the sort of large group of not overly stoic people that we have to deal with, and I think the advantage we've got is we're such a small hospital. I think with 60 odd beds, and our pain service, because our pain service is doing all those post-operative phone calls, and I've got a lot of non-pain round work to do, they're still always there for long hours, and they'll just head straight across the ward, and even if they'll just speak to whichever consultant they can. And also, we don't have registrars, we don't have anything, and we've just got consultants, so it's basically patient to pain nurse to consultant, and generally the person that actually anaesthetises them, and they're actually on site. So we've sort of got that luxury. that we can sort of intervene quite quickly from that point of view. And I mean, maybe part of it is that we kick them out so quickly that the day 2 blues we don't see, because we don't have anyone on day 2, but we still call them, and we have given them the expectation when they leave and given them good education around how much they're going to need and all that sort of stuff. And, you know, we do find that e-scripts have just been the most amazing thing, because we'll just literally send them out another script for another 20 of tramadol, they'll chew through that the first day. So I think the key to our success is just constant communication with patients.
Yeah, and what you said is about managing expectations. I think that makes a massive difference. You know, we've got, you know, the 60-year-old lady from Claremont who's concerned about whether the Game Ready is the appropriate ice machine that she uses. You know, it's a slightly different, but like you say, if you're managing those expectations like you guys are, and you're constantly giving that input, then maybe you sail through that transition. Yeah.
Other questions? Thank you everyone for coming. Feel free to stick around for some food and drinks at the end. So thank you to our speakers once again. And we look forward to seeing you in November for the next Journal Club meeting.